Hello, everyone. My name is Zach Maple, and I will be walking you through different aspects around the diagnosing, the research, and some treatment options in the area of depression and intellectual disability. A heavy amount of this information is provided from the Diagnostic Statistical Manual of Mental Disorders, 5th edition, TR, and the Diagnostic Manual of Intellectual Disability, 2nd edition, and the Handbook of Intellectual Disabilities. Many research journals will also be shared along with other book resources. The references can be found at the end of this slides. I also wanted to share a quote at the beginning of this. A Special Olympics International survey in 2022 found that 56% of medical students reported that medical school graduates are not competent to treat people with intellectual disabilities. That being said, I haven't been able to find any good quotes kind of equal to therapy and mental health support for people with IDD. We do know that this population needs help and is underserved. So hopefully some of this information will make you feel more comfortable in working with this population to help serve it. Depression occurs more often in people with IDD than in individuals without ID. Just a reminder about when we're talking about people with intellectual disability, we're talking about that the general mental abilities that affect functioning in two areas: intellectual functioning, such as learning, problem solving, judgment; adaptive functioning, activities of daily living, such as communication and independent living skills. Additionally, the intellectual and adaptive deficit begin early in a developmental period prior to age 22. A description overview. Depression refers to a range of mental health problems characterized by low mood, absence of positive affect, loss of interest and enjoyment, a range of concomitant behavioral, physical, emotional, and cognitive symptoms, and results in significant behavioral and functional disability. The challenge of working with individuals with an intellectual disability comes with teasing out what challenges does this individual typically present with versus what they are currently presenting with as far as behavior and functioning is concerned. An example might be, does this person typically have bad hygiene, or is this atypical? We might have to consult a family member or a caregiver to get a little bit more background information. Also, does this person typically like to spend time alone on walks, or are they usually pretty social people? The common features of all of these disorders is the presence of sad, empty, or irritable mood, accompanied by related changes that significantly affect the individual's capacity to function. So while attempting to provide a specific diagnosis with the criteria we will discuss, it will be important to think about the common features of all the disorders when applied to an individual with an intellectual disability. Example, does this individual appear to be sad or irritable? Have there been any reports of behavior associated with withdrawal from previously pleasurable experiences? Um, did this person maybe used to love spending hours building with Legos or doing arts and crafts or um, something like that, and they just really haven't touched them in a while? You'd want to get some background information to try to tease some of these things out. There's some initial impressions. So individuals that present with milder intellectual disability may present with symptoms that are similar to individuals that do not have an intellectual disability and would be more likely to be able to self-report with depressive symptoms. Individuals that present with moderate to severe intellectual disability would likely not be able to accurately self-report depressive symptoms, and diagnose treatment may rely more heavily on observations and caregiver reporting. It's important to remember, this is from the American Psychiatric Association, September 2022. Intellectual disability affects about 1% of the population, and of those, about 85% have mild intellectual disability. Males are more likely than females to be diagnosed with intellectual disability. So, taking the statistic provided by the APA, it would be much more likely that you'd be working with someone that has mild ID than more severe. Taking this into account, clinicians should generally feel more comfortable working with someone with ID if they are just looking at diagnostics on an intake form. So there could be some diagnostic overshadowing. That is when a person's symptoms of mental or physical ill health are overlooked or falsely attributed to being part of the person's intellectual disability. So we want to try to make sure to avoid that just based on what we're reading on an intake form or in the referral. So again, with working with somebody with a mild intellectual disability, it is much easier to have those self-reports and getting an idea of what's going on internally with somebody because they can self-report. Often aggression or agitation is the initial reason for referral for mental health evaluation. While aggression can have many different reasons for occurring, it is often the final common pathway for individuals with ID experiencing depression. If you think about it, aggression is a surefire way for someone to get notice when something is wrong, especially if the individual has limited communication skills or just having a hard time expressing those needs, as well as maybe not having a history of being allowed to express those needs. Individuals that attend day program and or live in a group home are often competing for attention from staff due to ratios. It is not uncommon for individuals in service to engage in maladaptive behavior for attention. So it is not easy to leap. It's not an easy leap to go from attention-seeking behavior to someone actually having depression. That isn't to say it should not be investigated. It is often more difficult for staff to pick up on depressive behavior as it will a lot of time manifest in behavior that does not draw attention to the individual. Think of withdrawal, right? If somebody is withdrawing from a group or withdrawing from conversation or trying to isolate, and you have larger group ratios, that staff usually isn't going to get kind of clued into that as easily as somebody that's making noise. So talking about the depressive disorders listed in the DSM-5 text revision, the following are the different types of depressive disorders outlined. Disruptive mood dysregulation disorder, major disruptive disorder, persistent depressive disorder, previously known as dysthymia, premenstrual dysphoric disorder, substance medication-induced depressive disorder, depressive disorder due to another medical condition, other specified depressive disorder, unspecified depressive disorder, and unspecified mood disorder. Just to kind of clue you in, if you're not as familiar with the DSM-5 TR, unspecified mood disorder has been added back to the DSM. Because of the absence of mood disorders grouping in the DSM-5 and DSM-5 TR, unspecified mood disorder is located within both the depressive disorders and the bipolar disorder chapters. I have a little disclaimer for this presentation as well. So the following are abridged descriptions of the diagnostic features, and clinicians should reference the DSM for further review and rule out of other possible diagnoses and a full list of specifiers. For the purpose of this discussion, there were no real major changes in the differences from the DSM-5 to the DSM-5 TR for this covered material. And here's a note of if you're looking for those specifiers for depressive disorders, you can find it here in the DSM-5. Of course, the only major change that we'll be talking about was the addition of the unspecified mood disorder in this section. So let's get into some of those diagnostic criteria. Disruptive mood dysregulation disorder. So here's some key diagnostic features. The core feature of the disruptive mood dysregulation disorder is chronic, severe, persistent irritability. Severe recurrent temper outbursts that could be verbally or physical that are out of proportion given a situation. The outbursts occur 3 or more times per week. The mood between outbursts is typically irritable. The mood has occurred for at least 12 months without a 3-month gap of reduced behaviors. Diagnosis should not be made before 6 years or after 18 years onset prior to 10 years. Also, the symptoms are not better explained by another mental disorder. An example might be autism spectrum disorder, PTSD, separation anxiety disorder. It also cannot coexist with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder. Major depressive disorder. Some key diagnostic features. Depressive mood for most of the day and nearly every day, diminished interest or pleasure in activities that have historically been a preference. This could include decreased appetite. Weight loss or gain that can't be explained, insomnia or hypersomnia most of the days, fatigue or loss of energy most of the days, feeling of worthlessness most of the days, recurrent thoughts or statements about death or suicide. 5 or more of these symptoms have to be present during the same 2-week period. You must use your best clinical judgment for symptoms in response to significant loss, so bereavement, serious medical illness, or disability. And with this, you need to use the specifiers with anxious distress, mixed features, melancholic features, with atypical features, with mood congruent psychotic features, with mood incongruent psychotic features, with catatonia, with peripartum onset, and with seasonal pattern. Also, I want you to, when you think about melancholic features, it really means that there's near complete absence of the capacity for pleasure, not just diminished pleasure. A tip for evaluating the lack of reactivity mood is that when even highly desired events, and you think of extremes like winning the lottery or going to Disneyland, something like that, are not even associated with marked brightening of the mood. So something that somebody's historically very excited, has high preference, and there's a near absence of pleasure. Through the literature addressing major depressive disorder in people with IDD is limited. There have been more papers regarding this specific syndrome than most others identified in the DSM-5, with the possible exception of autism spectrum disorders. This is with regards to depression being researched for individuals with IDD, not the population as a whole. I think as you'll see as this presentation goes on, that there is a real lacking of research with this population, and trying to get any kind of grand scale research projects done has really been lacking for a lot of it. So a lot of the research presented will be typically more smaller scale. Talking about persistent depressive disorder, some of the key diagnostic features: depressive mood for most of the day, for most days than not, for at least 2 years. 2 of the following present while depressed: poor appetite or overeating, insomnia or hypersomnia, fatigue or loss of energy, poor concentration or difficulty making decisions, low self-esteem, and feeling of hopelessness. This diagnosis used to go by names of chronic major depressive disorder or dysthymic disorder. The criteria is only 1 year for children and adolescents. So understanding low self-esteem or feeling of hopelessness would be very difficult to identify with somebody that has limited reporting skills. Think about those internal thoughts and those cognitive aspects that might be a little bit more difficult for them to respond to. Also, while working with someone that has had a brain injury, it is very common for those individuals to take more time than typical to recall information or produce an answer. It does not mean that they are depressed but the question might take a little bit more time to be answered. Clinician might want to pause for the answer and then rephrase if the question might be a bit too complicated. And in my experience working with individuals with brain injury that has a little bit of a delay when it comes to recall for information, everybody's slightly different. So you probably will need to figure that out as you're working with somebody if you want that genuine information while they're trying to respond. So it might take 10 seconds, it might take 20 seconds, and that 20 seconds might feel like a really long time. But if you want that information, I would pause and try to wait for them. And along with that, you might see that some people have had some uh, uh, forgive my train of thought, might have some prompt dependency from caregivers because they take too much time to come up with an answer. That you'll see some caregivers that end up prompting the individual or giving the answer for the individual. And this can be a challenge if you really want those authentic answers. And you might need to use a specifier with anxious distress with atypical features in partial remission or in full remission. Here's some specifiers: early onset, late onset, with pure dysthymic syndrome, with persistent major depressive episode, with intermittent major depressive episode, with current episode, with intermittent major depressive episode without current episode. Also specifying mild, moderate, or severe. Premenstrual dysphoric disorder. In the majority of menstrual cycles, at least 5 symptoms must be present in the final week before the onset of menses. Start to improve within a few days after the onset of menses and become minimal or absent in the week post-menses. One or more of the following symptoms: marked affective lability, mood swings, sudden sadness, marked irritability or anger or increased conflicts, marked depressed mood, feeling of hopelessness, marked anxiety, tension, or on edge. When I've seen this with an individual, it took a while to figure out. Tracking the incidence of behavior and how they lined up with her menses was how we were able to identify the diagnoses. It did take some time with some tracking of behaviors and mood by the caregivers to identify that this was actually lining up with her menses. One or more of the following symptoms to total 5 symptoms, including the prior slide symptoms: decreased interest in usual activities, subjective difficulty in concentration, lethargy or marked lack of energy, marked change in appetite, hypersomnia or insomnia, a sense of being out of control or overwhelmed. Also physical symptoms: bloating, joint or muscle pain. Another challenge for reporting could be internal states of pain or discomfort. This is why medical rule-outs should be tried first. Hyperthyroidism is a medical condition that could fall in line with the symptoms and should also be ruled out. Both PMS and PMDD can worsen during the years of perimenopausal. The symptoms may be more severe, and as periods become increasingly irregular, symptoms can be more frequent and certainly much less predictable, making PMDD harder to manage. In addition, PMDD mood symptoms are not present in the absence of a menstrual cycle. Thus, PMDD resolves during pregnancy and after menopause, where other mood disorders typically persist across all reproductive life events. Here's an interesting article with regards to this population out of the Journal of Pediatric and Adolescent Gynecology. It was found that in this study that it concluded that youth with Down syndrome, autism, or cerebral palsy were more likely to have pain during their menses compared to neurotypical peers. The study also concluded that the individuals would be more often to demonstrate the pain through behavioral challenges. And we already talked about that sometimes forms of depression can be manifested through behavioral challenges as well. Self-injurious behavior can occur when someone is having internal states of pain that are not identified. It is well researched that causing pain in one area of the body can decrease pain in other areas. If any of you have watched the show House, he demonstrates this process by actually hitting his hand with a hammer to reduce the pain in his leg. The history of the show basically has him in constant chronic pain in his leg due to an old energy, and he was self-medicating with opiates. And while getting off the opiates, he was having severe pain, and he used this method to actually reduce the pain in that area of his body. Also, understanding the increased risk of pain for these individuals would also lead to discussion with their physicians for maybe preventative medications to ease some of that pain. Substance medication-induced depressive disorder. So some diagnostic features around this: depressed mood or marked diminished interest or pleasure in all or almost all activities. Evidence of both. Symptoms developed during or soon after substance intoxication or withdrawal or exposure to medication. The substance medication is capable of producing the symptoms. An exclusion would be if symptoms started prior to the medication substance use or for a substantial period after ending its use. That seemed pretty clear cut, right? Also, this is the diagnosis that would be more applicable for individuals than diagnosis of substance intoxication or substance withdrawal when it includes depressed mood, marked diminished interest, or pleasure in all or almost all activities. I will say, with individuals I've worked with in the past that have a diagnosis of IDD, I have seen medication increase individuals' engagement in pleasurable activities and decrease those. I would say, though, that this is more typical for medication side effects rather than any kind of inappropriate use of illicit drugs. Primarily, this is just because individuals and services would have a harder time accessing illicit drugs due to oversight and limited access to funds for some individuals. Even when you think about marijuana dispensaries being completely legal for adult age individuals and adult IDD population, it's just generally more difficult for somebody to access. And if they're in a group home that's assisted through federal funding, it's still illegal to have on those residences. But it's more difficult because if somebody has difficulty with accessing the community, maybe they're not very good yet with taking RTD buses or can't walk long distances, can't drive themselves, and a caregiver doesn't really want to drive them to a dispensary, they can't even really access that if they had the funds. So we really see this as kind of a lesser diagnosis out of them all for the depressive diagnosis for the IDD population. And we have depressive disorder due to another medical condition. This includes depressed mood or marked diminished interest or pleasure in all or almost all activities. Symptoms are direct consequence to the verified medical condition. An exclusion could be the disturbance is not better explained by another mental disorder. So it's important to remember, a medical condition must be first established. Some examples of those might be Parkinson's disease, Huntington's disease. Depression can sometimes precede these major motor and cognitive impairments associated with the disease. With IDD, this might be found in individuals that have suffered a brain injury, a sudden significant loss of someone's ability to have been, a sudden significant loss of someone's ability to have been devastating to people I've worked with in the past. I work with somebody that has a brain injury right now, and up until he was about 17 years old, he was a perfectly healthy young man, and he had a major seizure and hit his head, and had partial paralysis on the right side of the body for the rest of his life up until now. I mean, he's I think late 40s, early 50s. So you go from having a very healthy lifestyle and being very active to then being very limited in your activities that you can have. And he's had clear indications of depression in the past. Prader-Willi could also fit with this diagnosis at times, but it also could be tricky to tease out. Someone that has Prader-Willi, they still have, if you're not familiar with that diagnosis, they still have a drive to eat large quantities of food and look like they're engaging in pleasurable activities. Eating is more about pain reduction and avoidance of feeling hungry than enjoying food, actually. Let me back up because if you're not familiar with Prader-Willi, it's a genetic abnormality, but that basically makes an individual have this constant feeling of hunger, and it's never actually satiated. And it kind of similar to polydipsia, but that's regarding more liquid intake, like they could actually drink themselves to death. Prader-Willi is a diagnosis that you're never actually satiated in food. They just don't digest calories the same way that we do as well. So since they can't absorb those calories, they're very limited on consuming. For instance, I was working with, I think she was in her 20s, and she was considered obese at the time. Her medical her doctor, her nutritionist, basically advised that she could only really have 1,200 calories based on her diagnoses and the amount of absorption it would have. And 1,200 calories is not a lot. It's really pretty limited. And if you know somebody with Prader-Willi, then you know that it's really hard to limit their ability on trying to consume food. So for them, it's more about pain reduction than it is about anything else, and avoidance of feeling hunger than actually enjoying food. So I've seen how behavior for food seeking of someone with Prader-Willi look like depression, but in reality, it was a behavior that was just needed to be supported. This person, she would get up in the middle of the night to look for food that was left out or in trash. She would then sleep most of the next day, and it would look like depression. Again, she would stay up all night. She would wait until her caregivers would fall asleep. So she would stay up waiting for that moment. And then she would sneak out into the kitchen and search if there were any food left out, because her caregivers would typically lock up the food just so she wouldn't be tempted. But she would even go through garbage cans and see if there was any food, anything edible. These individuals also have a history of eating things that aren't typically known as edible, for instance, like lotions, even Kleenex and toilet paper, those kinds of things, so that can help them feel more full and get that feeling of consuming some food. So what we found when she was doing this was that she was able to access the food. She kind of switched her days and nights. So she no longer was going to her day program, which she previously enjoyed. So it looked a lot like depression in the sense that she wasn't engaging in an activity that she previously did enjoy, and she was just sleeping all day. So we have a couple symptoms there that's kind of clicking for us, that thinking that it might be depression, until we discovered that she was staying awake late at night to sneak out, ensuring that her providers were asleep. And then we had to work with that behavior. Basically, what we did was, as a preventative, because she wanted help with this as well. She really did. So what we did, we created a program where we would go around the kitchen and we'd have a checklist. She would lead the checklist, and we'd walk around the kitchen and ensure that all the areas that would typically be a possibility for leaving things out were locked away and everything was safe. Now, this is a restriction. We'll talk about restrictions for people with IDD later on in this presentation in services. But once she started to feel comfortable that no food's getting left out, she stopped having that need for staying up late, because she already confirmed that nothing had been left out. And then she slowly was able to switch her days back, where she was able to sleep at night like she typically would, and then go back to day program during the day, which she really did enjoy. Some of those specifiers with this, with depressive disorder due to another medical condition would include with depressive features, with major depressive-like episode, or with mixed features. Then we have other specified depressive disorder. This category applies to presentations in which symptoms characterized of depressive disorder that cause clinically significant distress or impairment, occupational or other important areas of function, but do not meet the full criteria for any of the disorders in depressive disorders diagnostic class. This is used in situations that clinicians choose to communicate the specific reason that the presentation does not meet other diagnostic criteria. This one we see some more often than some of the other depression diagnoses, but the next one is even more frequent. Some examples for the specifiers would be recurrent brief depression, short duration depressive episode, so 4 to 13 days, depressive episode with insufficient symptoms. Now, this one is the one that we probably see the most, at least I've come across, because it's the most easy to diagnose with people with IDD, because you don't have to hit all the criteria when we're thinking about the individuals with not being able to identify some of those cognitive occurrences, what's going on internally with somebody because of maybe some challenging issues with self-reporting. Think about everything that's going on internally that requires self-report to be able to lend to diagnosis. So this is the same as the other depressive disorder. However, this is one where the clinician does not choose to communicate the specific reason. So it's the same as the last one. It just the clinician does not choose to communicate. So that's why one reason why we probably see this the most, at least I have come across with the IDD population. Then we have unspecified mood disorder. Again, unspecified mood disorder has been added back to the DSM-5 text revision. So this category applies to presentations in which symptoms characteristics of depressive disorder that cause clinically significant distress or impairment, occupational or other important areas of functioning, but do not at the time of evaluation meet the full criteria for any of those disorders in either bipolar or depressive disorder diagnostic classes. So this is used in situations that clinicians find it difficult to choose between maybe unspecified bipolar disorder and related disorders or unspecified depressive disorder. Because of the absence of a mood disorder grouping in the DSM-5 and DSM-5-TR, this unspecified mood disorder is located, again, within both the depressive disorders and the bipolar disorder chapters of the DSM-5-TR. I'm going to pause here and save the recording and take a break, and we'll be back with this next section.